Well, it is noon, and
Okay.
we are happy for you to join us for our CAP Grand Rounds. I have the privilege and pleasure of introducing Dr. Amy Mezulis, who is a licensed clinical psychologist who received her BA from Harvard University and her MA and PhD in clinical psychology from the University of Wisconsin-Madison. She completed her pre-doctoral fellowship at the Veterans Affairs Puget Sound Healthcare System, Seattle, and her postdoctoral fellowship at University of Washington Seattle Children's Hospital. Dr. Mezulis is the co-founder and chief clinical officer at Joon Care, where she oversees all clinical services and hires, trains, and supervises clinicians. She's also currently on the faculty at Seattle Pacific University, where she chairs the clinical psychology PhD program, supervises doctoral trainees, and teaches courses in adolescent development, cognitive behavioral therapy, diagnosis, and assessment. Her research has been funded by the National Institute of Mental Health, the National Association of Research in Schizophrenia and Depression, and the American Psychological Association. She has published more than 50 peer-reviewed studies on physiological, cognitive, and affective pathways to adolescent depression and self-injury, and is particularly interested in the joint contributions of environment and biology in mental health. Her clinical areas of expertise include mood and anxiety disorders, eating disorders, suicidality and self-injury, trauma, substance use, and adolescent development. Dr. Mezulis' approach to therapy typically focuses on improving stress management, coping skills and emotion regulation, reducing depression and anxiety symptoms, improving eating and sleeping problems, and coping with trauma or difficult life changes. Please join me in a warm welcome. Thank you so much for being here. I'm excited. I'm going to now mute myself and you can take the stage.
Okay. Thank you for that lovely introduction. Sam, does that screen look okay to you?
Good, perfect.
Perfect. Awesome. Well, thank you so much for inviting me. I'm really happy to be here. I have one student currently on internship at UCSF, and then a student who finished her program a year ago and is now off doing amazing things as a psychologist. So I've heard nothing but great things about your training program, and I'm really honored to be here. Thank you for the very nice introduction. Well, let's see what I'm doing here, doing my slides. I'll skip telling you about me because that was a beautiful bio and background, so we don't have to waste any more time on that. What I want to talk about today is the research that my lab has been doing in respiratory sinus arrhythmia and its influence on adolescent mental health outcomes, as well as increasingly we're interested in what is contributing to the development and changes in RSA across adolescence. So we're going to tell you a little bit about that, and I'll finish with some clinical implications and make sure we have time for discussion. And we'll skip that. I'm not always sure who's in an audience on physiology, so I'm going to take kind of a middle path on talking about what RSA is. And I will preface it by saying I am a clinical psychologist by training, and so I'm really interested in psychophysiological research and sort of what we can understand about clinical outcomes from the understanding or framework of physiological emotion regulation, but I do not pretend to be a biological psychologist by training. And so if you ask me to explain to you all of the math behind computing RSA, you'll probably see my eyes glaze over. But I would imagine that at least 50% of you, your eyes glaze over too, if you think too hard about it. So I'm not going to worry about it. But let's just start a little bit by sort of why are psychologists so interested in respiratory sinus arrhythmia? There's been just an explosion of research on this biological index that we believe tells us something important about emotion regulation. And so what is it? I mean, what are we actually measuring biologically, and why is it related to emotion regulation? I think is probably the best place to start. And then I'll move into a little bit of our specific research on it. So the easiest way for me to really understand RSA is to link it back to the basics of what we know about the physiology of breathing and heart rate. And so you can check this on yourself, you can do this with your patients, but if you just, if you're just measuring your heart rate, or if you wear an Apple Watch or a Fitbit, and you pay attention, you'll notice that your heart rate increases when you breathe in, and it decreases when you breathe out. And so these measurements that we get of our heart rate across a minute or across a period of time are really an average across time, because there's a tremendous amount of moment by moment, beat by beat variability in our heart rate. And that heart rate variability becomes an important component of what it is that we're trying to measure when we get to respiratory sinus arrhythmia. And so respiratory sinus arrhythmia, the other thing that's really fun about it is that everything you need to know is actually in the name, although it sounds really confusing. So what we're really measuring when we're measuring RSA is the variability or the arrhythmias in heart rate or our sinus rhythm across the breathing cycle. So that variability in how much your heart rate has increased when you're inhaling and decreased when you're exhaling is the sort of basic heart of what RSA is. So, okay, I've just told you something about breathing and heart rate. What does it have anything to do with mental health and emotion regulation? Well, we know that a lot of things affect our heart rate. Obviously age affects your heart rate, your weight or body mass index, your level of fitness, your cardiovascular fitness, all those things are going to affect your heart rate. And one of the things that influences your heart rate is the autonomic nervous system. And so the theory behind it, and I'll break it down in a minute, is that under certain conditions, we can isolate the influence of the autonomic nervous system. And specifically for our interest in emotion regulation, we can isolate the impact of the parasympathetic branch on that heart rate variability. And when we do that, and I'll talk both about the theory, and then I'm going to sort of leave the math to you to imagine. When we isolate that influence of the parasympathetic nervous system on heart rate variability, what we get is a non-invasive and objective index of parasympathetic nervous system activity. And then we start to go, oh, that's really cool. I could really start to understand how someone is using their regulatory aspects of their central nervous system. That probably does tell me something important about mental health. So we have a couple sort of important foundational biological theories that get us to really putting the pieces together about why this index of heart rate variability that we quantify through respiratory sinus arrhythmia, why this is able to let us make inferences about the influence of the parasympathetic nervous system. So I'm just going to very briefly review polyvagal theory and then neurovisceral integration theory as sort of the theoretical foundations for why we connect RSA to emotion regulation. So polyvagal theory basically says that there are multiple neural structures that are mediating our emotional, behavioral, and social responding to the environment, and that one of these pathways happens through the vagus nerve, which is the 10th cranial nerve. And the vagus nerve innervates many aspects of the brain and the body. We have afferent pathways that send information back to the autonomic nervous system that allows us to respond to environmental stimuli. And the vagal nerve is sending efferent pathways to a variety of outcomes, including cardiac functioning. Polyvagal theory sort of conceptualizes the influence of the vagal nerve on heart rate through this term, the vagal brake. It's a little overly simplified, but it's a helpful phrase to yoke to. And the idea of the vagal brake is that we are modulating heart rate in part by inhibiting the sinoatrial node. And we want to sort of keep a nice tight control on the sinoatrial node so that when we need to respond, we can release that brake and let the heart rate respond as it needs to environmental stimuli. But in the absence of needing to respond, we keep that brake on pretty tightly and keep it pretty well regulated. And as a result, then, when vagal tone is very high, when the vagal nerve is exerting that inhibitory influence on heart rate, what we see is that you have a lower heart rate. And with that, you're going to see high vagal tone then is associated with lower heart rate. And as we're going to get to in a second, that will indicate a higher respiratory sinus arrhythmia. By contrast, when vagal tone reduces, when we've sort of released that brake, it reduces inhibition, and that will allow the heart rate to increase. And so polyvagal theory is sort of the first theory that allowed us to understand how the sort of advanced cranial nerve system is allowing us to regulate cardiac activity. Neurovisceral integration theory really just extended polyvagal theory to sort of better explain the complex way in which the overall central autonomic network includes the higher order cognitive functions of the brain. And so in neurovisceral integration theory, we have this central autonomic network. It's comprised of the prefrontal cortex. It's comprised of the amygdala, the hypothalamus, and these in turn are innervating the heart through signals between these systems that do the same thing that polyvagal theory is saying is helping us to control heart rate through relative inhibition and releasing of inhibition of those signals in response to stimuli. Taken all together, what this says is that when we can isolate that one aspect, how the vagal nerve is affecting heart rate, then we have isolated the extent to which the parasympathetic nervous system is sort of actively inhibiting heart rate or has released heart rate, and we are isolating the parasympathetic influence on heart rate. We do this by measuring variability in heart rate in a very specific heart rate band, the high frequency band. You'll sometimes see in the literature high frequency heart rate variability, which is mathematically basically equivalent to respiratory sinus arrhythmia. And so as a result, what we believe that we are getting when we're measuring respiratory sinus arrhythmia is an index of the parasympathetic nervous system activity, and specifically the influence of the vagal nerve on the heart. Biologically, then, we have connected this through a series of studies to suggest that this is a biological index of emotion regulatory capacity for engaging in emotional responding to environmental stimuli. I think probably the best sort of review of this literature for those of you who are interested is this Bouchain paper. I think this is 2015. That sort of summarizes the research linking respiratory sinus arrhythmia with emotion regulation and psychopathology. And so this is a pretty long body of research at this point now, suggesting that RSA is, as Bouchain says, a transdiagnostic biomarker of emotion regulatory capacity, and thus tells us something about risk for psychopathology. Why do we care? Well, at resting states, we believe that a high resting RSA suggests that vagal brake is well engaged. We have high vagal tone. Oh, I have a typo in that. I hate when I have a typo. That's terrible. I'm embarrassed. But you know what I mean. So in terms of in a resting state, a high RSA would indicate that vagal brake is well engaged and that the parasympathetic nervous system is well regulating the rest of the of our responding system. The parasympathetic nervous system is engaged, it is active, and we are in a well-regulated state, prepared to respond. Low resting RSA, by contrast, seems to suggest a lower vagal tone. The vagal brake is not fully engaged, meaning that the parasympathetic nervous system may be a little bit less active, allowing that sympathetic nervous system to remain pretty influential on heart rate. And so you'll see things that start to get correlated, so that a lower resting RSA is likely correlated with a higher heart rate and breathing rhythm. But again, part of what we're trying to do here is really isolate that PNS. A long research of studies that I won't get into have associated then these this variability in these resting states with mental health outcomes of interest to us. So individuals with a high resting RSA seem to display better emotion regulation skills, better executive functioning, better resilience to stress, and less mental health outcomes of all sorts. Whereas a low resting RSA has been associated with internalizing problems, externalizing problems, and a variety of dysregulated emotion regulation and behavioral problems. I won't repeat all that research. What we've been working on over the last 8 years or so, 8 to 10 years, through 2 different NIH studies with young and middle adolescents, is understanding a couple questions about how RSA functions as a biological vulnerability to psychopathology among adolescents. And that's, I think, what I'm going to spend most of my time reviewing today is what we've learned through those studies. So we've been asking a couple questions. Under what circumstances does RSA predict psychopathology among adolescents? We've looked at RSA in environmental context. We've looked at RSA in the context of other indicators of physiological emotion regulation, in particular RSA reactivity to stress. We've also looked at RSA in the context of other emotion regulation skills that someone may bring to bear on stressful situations that would tell us something about their risk for psychopathology. And then we're also interested, since RSA does seem to be such a strong correlate of emotion regulatory capacity, an indicator of biological risk, we're interested in how it's developing and changing in this important adolescent transition. And so we also have a couple studies looking at stress and parenting as predictors of respiratory sinus arrhythmia. And so I'm going to review what we found in these studies briefly here. So despite the lovely big statement by Boucher about the literally thousands of studies linking low resting RSA with all these mental health outcomes, of course, when you dig into literature, findings are always a little less consistent than you would expect. And the relationship between resting RSA and depression in particular has been quite mixed. And so you find, there's a small to moderate effect size when you look across meta-analyses, but there are quite a lot of studies that find no relationship between resting RSA and depression, and some that find such a small effect that it would be hard to consider it sort of a meaningful biological indicator. And usually when we see patterns of findings like that, we start to wonder about whether or not there may be moderators of the effect that this physiological emotion regulatory index may in fact confer risk for psychopathology, but only for some children or only under some conditions. And that's sort of been the heart of what we've been looking at over the last few years. One of the theoretical frameworks that we have operated under is this idea from Ellis and Boyce about biological sensitivity to context. And so I'm sure you're familiar with this. This is the sort of idea that some children may be more biologically vulnerable to the effects of their environmental conditions. And that what biological vulnerability may mean is not necessarily always bad. It may just indicate sensitivity, that these youth may be more sensitive to negative outcomes in adverse contexts, but they may also be more likely to display positive outcomes in protective contexts. And so we sort of set out to look at low resting RSA as one of these biological indicators of sensitivity to context, because other studies have shown that low resting RSA may in fact confer risk, but only in adverse contexts, including being raised in a home with a parent with depression, in a home with a lot of marital conflict, is receiving harsh parenting, or has experienced other forms of child maltreatment. And so that was our sort of premise of the first study was, is resting RSA a risk factor for depression for all children or only under certain circumstances? And what we found, in fact, and this is our first NIH study, so this is 150 young adolescents, so an average age of just over 12 at the start of the study, ranging from 11 to 14 at start. And looking at resting RSA, a resting baseline, just watching passive nature scenes, looking at depression symptoms measured on the CDI, but looking at the relationship between RSA and depression in the context of the kind of parenting that these adolescents were receiving. And we had looking at parental responses to children's negative emotions, believing that the effect of an index of emotion regulatory capacity on an outcome like a mood symptom such as depression may be moderated by the way in which parents are socializing children to the expression and regulation of emotion in their household. And in fact, what we found was that low resting RSA was only associated with greater depression symptoms for children who were in contexts in which their parenting wasn't displaying a lot of support for their negative emotions. In the context of highly supportive parents, parents who supported the expression and regulation of negative emotions, we no longer found the association between RSA and depression. And so this started to help us understand that, in fact, perhaps low resting RSA may only be a risk factor in certain adverse circumstances in which there's nothing else to buffer that effect. So most research on RSA has focused on resting RSA. This is just RSA sitting while doing nothing in a resting baseline. Typically, children, adolescents, adults are watching passive nature scenes or engaging in perhaps even a guided breathing. And the idea is that resting RSA is really indexing someone's emotion regulatory capacity. Where are you? Your readiness to respond to an environmental challenge. Of course, what might be interesting too is also what happens when that environmental challenge is presented and what happens to that vagal break. Are you adaptively responding to that environmental challenge? And so most of us will show some RSA withdrawal, so a decrease in our RSA when faced with challenge. And we believe that to some extent this is adaptive. And if you think about what we're talking about with RSA, that it's this idea of the parasympathetic nervous system exerting a brake on your heart rate. Well, if the bear comes in the room, you really kind of hope your PNS backs off relieves that brake, allows your sympathetic nervous system to engage, allows your heart rate to go up so that you can adaptively respond. And so high RSA in the context of responding to stress may or may not be the most adaptive response. We probably want to see a flexible capacity for responding to a stressor or a challenge. It turns out this is a little bit harder to completely understand because how much is enough and how much is too little and how much is not enough. And so increasingly researchers are trying to understand the joint contributions of resting RSA and RSA reactivity in understanding mental health outcomes. And again, we're not 100% sure what to expect. We believe it probably has something like a U-shaped function in which we definitely want some RSA withdrawal, some decrease in RSA in response to challenge. But is too much too much? You know, if you just take that brake entirely off, is your car out of control and you have this sort of flooded SNS response? But what about if you don't respond at all? That doesn't seem like that would be adaptive or healthy either. And so that's sort of been the theory, at least underlying some of this research, trying to understand the joint contributions of resting RSA and RSA reactivity to mental health outcomes. And you might expect that, you know, we're sort of seeing a lot of mixed findings, but they're all sort of pointing to this understanding that you probably need to consider both contributions to fully understand someone's physiological responding to stress and how it represents their regulatory capacity. So Yaroslavsky and colleagues found that low resting RSA was associated with depression, sort of regardless of how someone reacted to stress, but that high RSA could also be associated with depression if the individual was also showing low withdrawal or even RSA augmentation to stress. And so this sort of has broken down this idea that high resting RSA is always adaptive. High resting RSA may no longer be adaptive if that vagal brake is so tightly applied that the person actually can't respond to challenge at all, that they show low withdrawal or even an augmentation of their RSA in response to stress. They may also show maladaptive outcomes. Huey et al. Similarly looked at adolescents RSA before, during, and after an anger task, and looked at sort of the RSA patterns for kids with good ability to regulate sadness, anger, and generate prosocial behaviors. And what you can see here, there's sort of a lot to break down, but there's a pattern where kids who showed either low RSA withdrawal or even augmentation to the anger task specifically, were not as well able to regulate their emotions or behaviors. And so we're seeing this pattern where perhaps low withdrawal or poor RSA reactivity may be associated with maladaptive outcomes. And the research is definitely pretty mixed. We do find some studies showing that very high RSA reactivity may be associated with hypervigilance, with emotional lability. Other studies have suggested, though, that high RSA reactivity may be associated with less psychopathology and better performance on certain kinds of tasks. Similarly, some studies suggest that low RSA reactivity may be associated with sort of a difficulty differentiating between stressful and non-stressful stimuli, sort of a failure of emotional responding, poor mood repair, depression, or anxiety. And so in our second study, we set out to sort of examine the joint contributions of resting and reactive RSA on adolescent emotion regulation. This is unpublished research currently under review. This is a sample of older adolescents, 650 18 to 24-year-olds, a college student sample. And what we're doing here is looking at resting RSA just in response to a passive nature viewing task, and then RSA reactivity to a Trier social stress prep task. And then what we're doing afterwards is for 1 week, we have an EMA where they're pinged 6 times a day for 7 days to evaluate their emotion regulation response to actual daily stressful events, looking at rumination and suppression as maladaptive emotion regulation, and problem solving and cognitive reappraisal as adaptive emotion regulation. And again, this is unpublished, so I'm just going to show you some sort of the broad, it's too many data points to report, but what we're finding is that, interestingly, we're seeing that sort of same pattern that Yaroslavsky found, which is that high resting RSA may or may not always be associated with the most adaptive outcomes, and that high resting RSA, when paired with low withdrawal, we may be seeing high use of these maladaptive emotion regulation strategies. So our older adolescents are reporting more use of rumination and more use of suppression when they have high resting RSA, but poor RSA reactivity. Whereas our adolescents with high resting RSA and high reactivity to stress actually are demonstrating some really adaptive skills in terms of problem solving and high appraisal. So a lot more to understand, but it's continuing to feed this idea that we need to be examining both resting and reactive RSA if we want to fully understand how RSA indexes emotion regulation in adolescence. And then finally, in terms of moderators of RSA, we've also been interested in sort of this levels of analysis approach, right? So we're looking at physiological emotion regulation, but most adolescents are also raised in homes and schools and other contexts where they're acquiring other behavioral and cognitive emotion regulation skills. And so they enter into their stressful events with a whole variety of physiological, behavioral, cognitive emotion regulation capacities and skills that are jointly contributing to how they function and respond to stressors. And so one of the questions we were asking in this study was, when this high RSA reactivity, because in theory, too much reactivity seems like it should be bad, but this body of research is sort of starting to suggest that high RSA reactivity could be adaptive in some circumstances. We set out to understand that a little bit more. And what we're looking at here is engagement in non-suicidal self-injury, also among these older adolescents. These are also 18 to 24-year-olds. And what we found is that being sort of physiologically high in reactivity, so having a high RSA reactivity, was associated with engagement in SSI, but only for individuals who had poor problem-solving skills. Individuals who had high problem-solving skills, if they had other good behavioral strategies to bring to the fore, it was okay if they were physiologically highly reactive. They were actually doing fine as long as they had these other skills to rely on. And so I think, we'll connect back in a few minutes here to clinical implications, really understanding these sort of joint contributions of emotion reactivity, emotion regulation, and other emotion regulation strategies can be really helpful to us clinically. So sort of talks a little bit briefly about our first sort of line of research is what circumstances does RSA predict psychopathology among adolescents. In the last couple of years, I've also been interested in how does physiological emotion regulation sort of develop and change among this age group, and in particular interested in the impact of stress and parenting on RSA during this important adolescent transition. So, just a very brief sort of context setting. I mean, we know that adolescence is a critical period for the development of emotion regulation. We know from a series of studies that RSA is dynamically influenced by age and environment throughout childhood and adolescence, that there's a normative decline in resting RSA across development. So on average, RSA is trending down over time. We also know from research on other domains of emotion regulation that stress is often associated with poor emotion regulation skills in adolescence. If you're faced with too many stressors, especially before you have the skills to really handle them, that can negatively impact your ability to acquire those emotion regulation skills. We also know that adolescents are learning those emotion regulation skills in context, and in particular that parenting has a big influence on the emotion regulation skills they develop. So sort of taking all this research together, we were curious about whether stress and or parenting together, separately or together, would influence trajectories of resting RSA across adolescence. And so we've done this in a couple ways. I'll walk through two papers, similar samples. First is 150, the same young adolescent sample from study 150 young adolescents. The second study is that study plus another cohort, and that N is closer to 270. But what we looked at here was total stress exposure over 1 year and looking at changes in resting RSA across 12 months. And what we found was that total stress exposure over the course of a year did in fact predict declines in resting RSA, but only if those highly stressed adolescents were experiencing low supportive parenting. Kids who were exposed to stress but had supportive parents showed little to no decline in their resting RSA. And so this comes back to in sort of a developmental trajectory approach to us understanding, that not only does the impact of RSA on outcomes depend upon context, but impact that feedback loop to how experience is impacting physiological indicators of emotion regulation, which are themselves developing in adolescence, is also highly influenced by context. And so, in fact, stress is exerting a negative effect on resting RSA, which we believe indicates emotional regulatory capacity. But that effect is really only going to be present if we don't have parents who can help children in a supportive way cope with those stressors. We just extended this research with our broader sample and by looking at more specific domains of stress rather than sort of a global stress exposure measure. We were able to use the life stress interview from Connie Hammond's work and look at very specific domains of stress. And here we found that family and marital stress in particular, so the stressful context that experienced by the youth, particularly in their home environment, in paired with parenting styles, were what were predicting those trajectories of RSA. And so the strongest effects for the domains of stress were found for family and marital stress. What we found was that children who were across a year experiencing high family stress and then highly rejecting parenting had the lowest resting RSA across that year, whereas kids who experienced high marital stress but also experienced high warmth actually had high resting RSA. This was really interesting to us, and I think the way we're thinking about it is, again, circling back to that sensitivity to context model, that some of these youth may be particularly sensitive to context. And so stress in and of itself was not enough information to understand how their RSA was being impacted, because if they were in adversive context, in highly rejecting context, it had a negative effect on their emotion regulatory capacity. But if they were in supportive context, they were experiencing that stress in the context of high warmth that may support them in coping with that stress. Actually, that was contributing to higher resting RSA and perhaps better emotion regulatory capacity. So some clinical implications that we're thinking about, I think we're continuing to see that respiratory sinus arrhythmia is associated with mental health outcomes in adolescence, that we probably need to be considering the joint contributions of resting RSA and reactive RSA. We also need to be thinking about the fact that this physiological emotion regulatory index is itself developing during this time frame. One thing that sticks out to me clinically is this idea that stress itself is not the enemy. It is not what is either causing mental health problems nor causing ongoing physiological dysregulation, but that understanding stress in the context of other environmental features, particularly parenting, may be really important, and that individuals who are faced with stress but experiencing supportive or warm parenting, or may have other regulatory skills such as problem solving, may not show the adverse effects of stress on their mental health outcomes. And we saw that with high RSA reactivity in response to stress, predicting NSSI, but only for kids who had low problem solving, seeing that stress was predicting declines in resting RSA across time, but only for kids who are experiencing rejecting or low supportive parenting, that there are ways in which we can expose kids to stress and actually support or buffer their development, both of mental health and of emotion regulation. The last clinical implication I'll just talk about briefly is, in addition to things like, understanding how other things that we can do in clinic, like building problem-solving skills, can support our clients who may have physiological vulnerability to mental health outcomes, is that there's sort of an accumulating body of research that we can impact someone's heart rate variability or respiratory sinus arrhythmia with interventions, and in particular meditation, mindfulness, and mindfulness-based stress relaxation have all been shown to at least have short-term impacts on increasing resting RSA. There's sort of an absence of long-term data on this, but I think that's an interesting way for us to think about it. And to me, it sort of clinically pulls full circle some of what we do instinctively in working with our clients in terms of helping them build relaxation skills such as deep breathing, the capacity to practice mindfulness, meditation. That one mechanism of action for these interventions that we've been using for a long time clinically may be that we're helping people develop greater physiological emotion regulatory capacity through those interventions. And so I always like that when something that I'm doing clinically has a sort of physiological underpinning to it that the research is supporting. And I think I will stop there and happy to discuss any of this, sort of where this research is going, sort of unanswered questions. I went through a lot of studies very quickly, happy to answer more detailed questions about those studies as well.
Thank you so much. I do have a question, and please, folks, I don't want to monopolize the time as the host, but please put your questions in the chat. But that last point about the bidirectionality of changing, right? So we often talk about what are the biological predispositions that make someone, right, vulnerable for having emotion dysregulation. Can we then reverse it, right? Can we make that biological regulation better with the emotion regulation skills? Can we change someone's biology? And I'm wondering if we can talk a little bit more about that last piece. And
sure.
Yeah.
I mean, I will say, so this is not my research, right? I'm putting up other studies, but it is. So I think there's a two-sided answer if I'm understanding the research clearly, and then I'll maybe talk briefly a little bit of sort of clinical speculation. But I mean, there are quite a lot of studies now showing in lab studies that if you do a mindfulness or meditation induction, that you can even just simply a paced breathing exercise, what you'll see is that someone's resting RSA does increase a little bit, suggesting that those interventions are impacting their physiology right there. And if we believe then that physiology is an index of their emotion regulation capacity, right, the chain of logic there would suggest that yes, in fact, we are. Now, I think the pieces that are missing are twofold. One is, are those, what's the dose that we need to see long-term impact? And I don't think we have good data on that. We know in lab studies that we can influence someone's resting RSA in a relatively short-term basis. How long that could last over what kinds of stimuli is less clear. Or at least I'm not as familiar with that research. The other one is, and this is a little bit of a like geekier one, which is there are some studies that are suggesting that what's happening with meditation and paced breathing specifically is maybe actually is not impacting the high frequency HRV. It's actually impacting the low frequency band of HRV. That you might still be seeing it in your measurement outcomes, that perhaps we're not actually altering that sort of PNS break, which is what we're interested in, right, as you go back. And so I think there's still a decent amount of missing dots. But if we also think about what we're, when I'm thinking about emotion reactivity and regulation, I'm really thinking about a continuum of responding, right? And if you think also about my early waves of research, we're all about cognitive reactivity and cognitive emotion regulation. And, if you think back to some of the early studies on how is cognitive therapy working, right? Like, are we really stopping people's automatic thoughts, or are we just helping them better catch and challenge them, right? Like, where in the reaction response are we actually catching? I kind of use the same analogy for emotion regulation interventions, that it might be very difficult to stop someone's like immediate emotion reactivity, but the faster we can get those emotion regulatory skills on board closer to the point of reactivity. And in some ways I'm like, if they're functioning better, if the manifest outcome is better functioning, am I going to nitpick over whether I have changed their biology or not? I don't know. I mean, I've changed a piece of it, right? Because their physiological emotion regulation is a piece of that whole continuum. Have I gone all the way back to the source? I don't know. And this is we're way past my sort of core of my research now, but those are my thoughts on it, if it helps at all.
Yeah, I appreciate your response. Thank you. It's very nuanced. I appreciate it. Tony, you can go ahead and unmute yourself and ask your question.
Sure, thanks. So thank you for a great talk. I had two questions. So I've done a lot of research and published papers looking at adolescent depression and neuroimaging responses. And so we've found and published papers showing that in depressed adolescents, the amygdala is overreactive. And the autonomic nervous system has a lot of direct connections with the amygdala. And we actually currently have an NIH grant using mindfulness meditation. And the first module actually involves breathing exercises. And our hypothesis is that it, through the autonomic nervous system connections between the brain, so in this case, the amygdala and autonomic nervous systems, that the breathing exercises actually help quiet down the amygdala and help with reducing depressive symptoms. One of the things that we've run into with reviewers is that with heart rate variability, I didn't realize this, but at the time we tried publishing a paper connecting amygdala activation using MRI in depressed adolescents with heart rate variability. The reviewers were fine with our MRI neuroimaging data analysis, but we got really hammered on our definition of heart rate variability. And I didn't realize there was such a controversy in terms of definitions of heart rate variability and, decisions of whether you look at high frequency or low frequency and all the analysis. And I'm wondering with RSA, is it more, have people settled on a definition of RSA that, if you were to submit a paper looking at physiological measures of and neuroimaging, whether we're going to run into the same problems with
it's a great question. And again, I'm going to preface this by saying, psychophysiological research is one piece of what my lab does. My lab is really an emotion regulatory lab, right? I'm really interested in multiple levels of analysis. And so I wouldn't consider myself the expert on the quantification of RSA. But I would say that at least our understanding, sort of how when I was training to use RSA and sort of selecting our sort of scoring, we use Mindware to quantify and yield our RSA values, that it is equivalent to high frequency heart rate variability, and though that frequency bands are age you have to control for the respiratory cycle, and depending on the sort of fine-tunedness of your respiration band, we actually don't collect respiration. We collect it a little bit indirectly through impedance. But what we've been able to do is use some of the published metrics for what we consider to be specifying that high frequency band by age and gender, and then having bands of BMI that we don't go across. Like, we're not working with older adults who might have really significant other sort of health impacts on their cardiovascular functioning, right? We're working typically with healthy children. And so then if we can just focus on height, weight, and age to identify that high frequency band, we have not gotten pushback on calling that RSA once we define what the high frequency band is and sort of validating that it was the appropriate high frequency band for the quantification of the heart rate variability inside of it. Does that help?
Yep, that's great. Thank you. And then just a second quick question is, have you found any evidence to support that if you use your physiological data that you've collected to try and create different subtypes of depression, whether that you can match with specific treatments that are more effective, since we know depression
I don't do any treatment research at all. We have tried to identify we've tried to use latent group analysis to identify sort of subgroups of RSA responding, both in terms of resting and resting plus reactive. We have a very hard time getting any of these latent models to fit. I can define, right, like high-low reactivity and high-low resting baseline and high-low reactivity. I can on my own define it, and I can see patterns in terms of emotional regulation and symptoms, but I cannot get the data to confirm that model fit at all. And I've tried it across a couple data sets. I have my own data set, and I have a pooled data set that I've worked with some colleagues in Belgium. But I've never tried to connect it to treatment outcomes. And I'd have to go back and think about the last time we looked at the different sort of, undata verified subgroups in terms of resting and reactive RSA and what we were seeing in terms of symptoms. We were able to see a sort of like failure to respond type, and then a sort of more clearly dysregulated type at high levels of reactivity, but I'd have to go back and look at it in more detail.
Okay, thank you. Appreciate it.
Anne, you have a question you put in the chat you'd like to unmute?
Yes, I really apologize because this is with my phone. I was actually in another meeting on my computer. So thank you for this really wonderful talk. I know that you said that you don't do treatment research, but then I would be interested in knowing how you phenotyped parental support along high and low, because that's important.
Sure.
And also just highlighting how common I think the clinical situation that you describe is of a dysregulated, stressed child through multiple pathways, obviously, because as you know, emotional dysregulation that you're measuring probably can have multiple phenotypic origins, but how common it is to have that in the context of low support parenting.
Totally. Right. I mean, we start to understand that, right? These children didn't become dysregulated, right? They were not simply just born that way. They may have come with some biological vulnerability, and then unfortunately they've been raised in a context that has really continued to not give them any regulatory capacity.
And exacerbated it, right? It's also over time we also see that it's not just low support, it's an exacerbating environment.
Absolutely. No, I think that's exactly right. And I was going to say, this comes back to Barbara's question earlier about that I meant to say that, and this is not something that I know a lot about. I've just been starting to read, but I am really interested in sort of the polyvagal therapy and this idea of co-physiological regulation as an important part of the social. So polyvagal theory at heart, right, is about social behavior. And so, and again, this is not the research I do, but I'm quite interested in the extent to which we physiologically co-regulate with other people around us. And to me, that might be an even sort of third leg on that stool of why these dysregulated kids are so dysregulated. It's not just the stress and the environment, it's that they've had the failure of this sort of co-regulation that we might have expected right across development. But to come back to your first question about how do we measure parenting? So these are all in our studies, again, because we're taking a broad view of multiple levels of emotion regulation, is that this is all self-report measures, but both by child and by parent. On typically, I have two in here. One is a parenting measure, and I'm not going to think of the name of it right away, but it's a pretty standard parenting measure on like warmth, harsh parenting. That's a straight up parenting measure. But the other one that we've used most is the CCNES, which is a socialization to emotion questionnaire. And it's a set of scenarios that both children and parents respond to, which sort of ask children and parents, like, if your child had this emotional response, what kind of feedback would you give them about how to regulate it? And that is where we get that supportive, that low supportive or high supportive parenting from, as opposed to an invalidating response, is really direct parenting about the socialization of emotions. And for our research, we typically, although sometimes it sounds like you would want the parent report to like not have the same reporter, we typically use the child report because we're really interested in the child's experience of the parenting that they're receiving in terms of what messages they believe they're hearing about the socialization of emotions. So that is that's that parenting measure, and that's been really interesting to us to look at. That's a sort of an even separate line of research on how parents socialize children to the regulation of emotions, and we've looked at that parenting measure both in response to negative emotions, but also in response to positive emotions as well.
That's wonderful. Did somebody put the name of the abbreviation that you gave? CCS. What did you say?
CCNES is the
CCNES. Okay.
That's the acronym. The NE is negative emotion. So I assume the P, like the positive one, must be the P. But and I'm sure it ends with scale. And probably one of the C's is children. I can look it up. It's so
no, that's great. I can look it up too.
Happy to respond back with the actual measure.
Thank you. Thank you very much.
It'd be in one of our papers too, the full name of it. I'm
Thank you
terrible
so
at that
much.
sort of thing on the spot, like what that acronym means.
Rashid, you can go ahead and unmute yourself if you want to ask your question.
Sure. Yeah, thank you, Amy. It's really interesting information and a very helpful formulation of parasympathetic and polyvagal and this RSA. I'm wondering just what has been kind of correlated, kind of along with Tony Yang's question about like the brain networks and default mode network and how that might correlate with RSA or inversely correlate, and then kind of corollary to that question is, has there been any look at how psychedelic medicine affects the resting RSA?
Oh, well, your second question is super interesting, and I will say I have no idea. But I would be very curious to know. I hope no one's doing that research with children and adolescents, though, at least not yet. But the first question, I'm not a neuroimaging researcher, and I would think the best place to look for a summary of that research on neuroimaging studies and RSA is probably that Bouchain chapter. I believe part of his sort of review of the literature reviews some of the sort of basic brain science research connecting RSA, and also, of course, all the research sort of associated with the neurovisceral integration theory and RSA takes that approach and probably integrates that, but I don't know that off the top of my head. I'm sorry.
Thanks, David Becker, for putting the link to the CCNES.
Oh, thank you.
Any other questions? Anyone can go ahead and unmute yourself. I can't see if you're raising your hand.
This is Tony again. So, there's so few really effective treatments that we have for adolescent depression. So I just wanted to thank you for this presentation. I would encourage you to continue this work. And the question I'm wondering is that, as a parent of a budding teenager, I'm just wondering, what have you found in your research? What was it specifically that the parents did that was basically helpful for emotion regulation with the teens when they encountered stress?
Sure, that's a great question. And I'd have to, of course, these are all self-report measures. It comes back to the other question about what exactly those measures are in terms of, what we would consider, what are the actual indicators of warm parenting or supportive parenting. So I think that's a great question. I'd have to go back and look at some of the items on that. I will say one of the things that has stuck out to us in this research is, we're using community samples, so that can affect some of the outcomes as well, is it's not always the presence of this like harsh or rejecting or invalidating parenting that is associated with negative outcomes. Sometimes it is the absence or the lower ends of these supportive parenting approaches, right? That and the way I sort of, and I have two teenage daughters, a 16 and 19-year-old daughters, is that very high support. So the supportive parenting, at least how we frame it, is that CCNES. So it is high support in the context of negative emotions. And what that is typically on that measure conceptualized as is validating the emotional response and then supporting the use of effective emotion regulation strategies. So what the parent is doing is validating the emotion and sort of supporting or guiding the application of sort of healthy emotion regulation strategies, however conceptualized by that measure. The other ones, which are more on warmth versus harsh parenting, are a little bit more generic parenting measures around sort of like warmth and love as opposed to specific techniques. But that's part of why I like the socialization of emotion, because those really are very specific situation based that I think we as parents can really understand. And one of the things I always do, and I do a tremendous amount of parent training. I'm doing much more clinical training, clinical work now than research. One of the things I do in my parent trainings is talk about that. How do we respond to our adolescents' negative emotions? And the very first thing is to remember the importance of that validation step. I think all of us as parents click very immediately into either what can feel very invalidating to the adolescent. Oh, it's not a big deal. It's not, because we don't want them to be upset. We don't want them, we want to temper their emotional reaction in a way that can come off very invalidating. And then we go immediately to problem solving, and we forget that important first step of the validating of the emotional experience of the adolescent. And sometimes that is 90% of emotion regulation, is simply allowing the emotion to be experienced, and whatever emotion regulation strategies they have to start coming on board, but to start there, and only from there then move to guided emotion regulation, which is not us as parents doing the problem solving, but supporting the adolescent in generating and implementing the strategies that are accessible to them to do that. And that's, I think we all could understand that, at least conceptually, that that's part of how you scaffold emotion regulation development. It's not by doing it for them, but it's by supporting them in the use of their own skills.
All right, thank you. That was extremely helpful.
Amy, how much do you think this is could be translated to peer groups and bullying and peer interactions and invalidation in the peer in that kind of social context?
Yeah, I think we have a little small line of research on co-rumination, and I think about that, and especially for females, we've really seen this sort of double-edged sword of this co-ruminative process, right, of problem talk and sharing my distress with my peers, where on the one hand it builds social networks and social support, and we know that appropriate emotional disclosure can lead to stronger social networks and can be effective in terms of reflection and problem solving. But excessive emotion disclosure, sort of shared emotion, empathetic distress, and the aspect of it that sort of exacerbates and brings everybody up. And so I think it's going to be one of those times where you have that kind of U-shaped function where there's an amount that's really healthy and adaptive for co-regulation, and then a place where it becomes like too little is not good. You're not relying on your social support network, but too much also might just send us all into a dysregulated frenzy. And with teens, especially, all those gray zone things are always just a little bit harder to get them to understand. And I think, I do a lot of work with dysregulated youth, and that's, to me, part of that DBT approach, right? Of how do I find that sort of, wise mind middle ground on what is not letting all my emotions rule, but what's also not letting my rational mind sort of take over, is kind of how I think about it conceptually. But I think, if we believe that an aspect of physiological regulation happens socially, happens through co-regulation, then peers are an important, vehicle for that. But I think just like any co-regulatory process, there are ways in which that can be adaptive and ways in which that can't, depending on the context and the way in which it's done.
Thank you for that.
Yeah. Thank you all for having me. I really appreciate the invitation.
Yeah, thank you so much. I can't wait to see this next round of research that you're doing. It's so complex, right? And you're just
regulation, adolescent development. What's complex about that?
Yeah, piece of cake, and disentangle all the different components of it. So thank you for all the work that you've done. We should end there. Last call for a question. We have like a minute and maybe 30 seconds. Oh,
yep,
Tony, I can count on you to get.
Yep, I'll get in that last question in 1 minute. So thank you again for a wonderful talk. I'm just wondering, do you have a website, or if we email you, do you have any resources that we can maybe give to parents about helping their teens? Because we see a lot of teens, and
Yeah. I'd probably direct you, and I apologize, it's going to sound like self-promotion, but you asked a question, so I'm answering it. But my teletherapeut company, which is Joon.com, JOON.com, we're all adolescent, young adult mental health, and it has a whole resource page that has freely available resources for parents, for adolescents, on mental health topics, on understanding mental health, that are sort of more publicly available and accessible for teens and young adults. You'll also, if you're interested in my research personally, you can always email me. My email is just my last name, Mezulis @spu.edu. And I'm always happy to connect you to my to any of the research that I have. Most of it's, of course, searchable on Google Scholar, ResearchGate too. But that Joon.com website actually has a lot of freely available resources.
Okay, great. Thank you.
Sure.
Thank you so much. Have a great
Yeah, thank you. I appreciate the invitation.